to the Make a Mental Note podcast, where mental health professionals share information and perspectives that illuminate, educate, and is worthy of a mental note. And now your host, Chris Quarto.
Hi, everyone. Welcome to the Make a Mental Note podcast. I'm your host, Chris Quarto. As always, I start out my podcast with a mental health tip of the day, and today's tip has to do with calming yourself down. You know, some people find it difficult to calm themselves down when they feel angry or anxious or when they're upset about something. And if this happens to you, then there's a very simple technique that you can use to help. And it's actually something that you do every night when you sleep, and that is deep breathing. Whenever you feel yourself getting worked up about something, learn to recognize this and use it as a cue to slow down your breathing. Sort of like how a red light on a traffic light is your cue to slow down and stop when you drive a car. So here's how it works. Count slowly inside your head from 1 to 5 and slowly breathe in through your nose while doing so. And if you do this the right way, you'll find that your tummy, your stomach expands. And then immediately count backward from 5 to 1 and exhale slowly through your mouth while doing so. And then repeat this about 5 to 10 times. Now here's the thing. You won't totally get rid of your anxiety or anger when you do this, but it'll definitely help to take the edge off. And it may prevent you from reacting to something in a way that's not helpful. So that's my mental health tip for the day. Okay, here is my interview with today's guest, Stephanie Eken. It's time to introduce my guest, Dr. Stephanie Eken, who serves as a regional medical director for Rogers Behavioral Health System's partial hospitalization and intensive outpatient programs. And we have a new location located here in Nashville, and so I'm sure we'll hear Dr. Eken talk about that. She also provides medical leadership for Rogers Obsessive-Compulsive Disorder and Anxiety Disorder Services. So welcome to the podcast, Dr. Eken.
Thank you so much for having me.
Yeah, this is great. Well, if you wouldn't mind, just share a little bit with the mental note-taking audience a little bit more about who you are and what you do for a living. Yeah,
well, I am back here in Tennessee and excited to be back here after being in Wisconsin.
Uh-huh.
I am a triple-boarded physician, so I have a background in pediatrics, psychiatry, and child and adolescent psychiatry.
Okay.
I've practiced in Louisville, Kentucky. I did my residency actually at the University of Kentucky in Lexington, but I've been out and practiced in Louisville and then was up actually in Wisconsin at some of our programs for Rogers up there, where I ran a residential program for kids with OCD and OC spectrum disorders. And then this year, moved back here to Tennessee and am overseeing our Nashville location, which opened on May 4th. And I'm also overseeing our Tampa and Chicago locations for our psychiatric care.
So you are a very busy lady.
I am. Sometimes I am not sure what city I'm in, but the fortunate thing is I have been able to spend the majority of my time in Nashville over the past several months now that we've opened up here.
Yeah, and I guess that's what I'd like to talk a little bit more about, is that there's a new Rogers location here in Nashville. So if you wouldn't mind to say a little bit about that, what kind of services are offered and how people could get involved with your services.
Sure. So we, Rogers is really what we're known for is our specialty mental health services.
All right.
So we have specialty programs up in Wisconsin, and what we learned is that some of our families needed different levels of care in several areas around the country, and Nashville was identified as a place where we got patients from who came up to Wisconsin to our residential programs, and you know we'd love to keep them in their area. So what we did is we opened up in Nashville programs focusing on OCD and what we call OC spectrum disorders that people might know as they might have heard of body dysmorphic disorder or trichotillomania, where people pull their hair. those type of disorders that we see, and other anxiety disorders or phobias where they have a specific fear of something. So we opened up child and adolescent programming for that. So we go from 6 years of age up to 18 if they're in high school, and then we have adult programs for that. We have what we call partial hospitalization programs and intensive outpatient programs, and the differences are really the amount of time that they're spending, here with us during the day. So we have all of those programs open, and we, in October, will also be adding eating disorder services for children and adolescents, both males and females. Yeah.
Fantastic.
So that'll go down. Yeah, we're really excited. So we'll be treating kids from age 10 up to 18, again, if they're in high school. And we'll have both levels of care, both the partial hospitalization, where they're here for 6 hours a day during the week, and then our intensive outpatient program, where they're here 3 hours a day during the week. So.
Well, I'm really excited to hear about that because, I think in this area that there was a lack of certain types of services for children and adolescents, and to hear this going on, and it's just really exciting, I think, for a lot of mental health professionals in this area to have that as another resource. So on behalf of mental health therapists across Middle Tennessee, we really appreciate that. If you wouldn't mind, the audience may have heard you say that phrase obsessive-compulsive disorder, and I think that they might have a general idea of what that is, what it means, but maybe you could say a little bit more, kind of explain what that's all about.
Sure, yeah. So a lot of people have knowledge of OCD from movies or TV shows, but OCD can look like a lot of things, and then, of course, the core pieces are people have obsessions, so they're really unwanted thoughts that are intrusive, so they can't control it if they come in their head. And so it may be something that people know commonly that they might see in the media is something like extreme fear of germs or extreme fear of becoming ill. So they have all these thoughts about, worries about that they might become sick. And so then they have what we call compulsions, or other people call rituals, in that they do things in order to try to prevent the feared outcome. So like if, for say, they were concerned about becoming ill, they might excessively wash their hands. Or they might avoid touching things that they would consider to be, germs on them, such as like a doorknob, or, really commonly they might avoid public bathrooms because those can be associated, in a lot of people's minds with a lot of germs. And it can be really impairing. So, these obsessions can take up a lot of time, and as well as these compulsions or rituals, so much so that sometimes people, can't work or go to school. Now, other times people can still do those things, but it's still impacting their lives in a lot of ways, in relationships or whatnot. And then they also tend to have a lot of what we call avoidant behavior. So they may just avoid going out in public, let's say if they're afraid of becoming sick, like especially during flu season, because they feel like they're more at risk. So, so they just do a lot of things that that sort of reinforce this idea that things are really dangerous when, most of us could do, wash our hands at normal times or those kind of things. So, so that's a basic example, but OCD, I think it's important that people know, has a lot of other forms other than contamination and fear of becoming sick. It can be things such as religious concerns, so that they might have a lot of fear that they would go to hell if they did something like if they told a white lie or something like that, is an example. Or it can be also with what we call harm obsessions that I think people don't know a whole lot about, but I think we see very commonly where people have these unwanted thoughts or images in which they have these thoughts that they might harm somebody. Now, they're the least likely person to do it because they're unwanted thoughts, but they can't control that these thoughts are coming in their head, and that's very distressing, right? If you have thoughts that you want to harm somebody, but you don't really want to do that. So OCD can really span a lot of different areas. So it can look different in people, but the core piece is having that obsession and compulsion piece.
Okay. So, and, I hear that, and, I've had clients who have experienced OCD, And of course, I've gotten this question over the years, and I'm curious to hear your answer to this as well. It's the $64,000 question, and that is, why is it that people get this or have this disorder? I mean, how does this develop? Why do people have this disorder, Dr. Eken?
Yeah, well, it's a great question, and there's not one single answer, that we can just neatly say that this is the reason. Now, there are several things that we know play a role in developing OCD. Certainly, if you have a close family member who has OCD, we believe that genetics play a role. So if a parent has a child, then and they had OCD, then there is some risk of genetically passing on OCD. So there's that component.
All right.
Certainly, it's not 100%, but we know that it runs more in families. And then if you also have significant stressors, so sometimes a significant negative life event occurs that can trigger someone who already sort of maybe has some tendencies towards anxiety or OCD, so a negative stressor can do it. And then there's this other piece that's not as common but out there, but there is something called PANS, where it's a pediatric autoimmune neuropsychiatric syndrome, in which we believe there are infectious triggers for OCD. So
interesting.
Streptococcal infection is one. There's been some association with flu, certain flu bugs as well. So sometimes those can also trigger off OCD. So there's a variety of reasons why people can develop OCD.
Okay. So mental note takers, I guess, from what I heard, the answer to that question has to do with genetics. I guess that plays an important role, as well as stressful life events, environmental conditions as well, and the possibility of some sort of an infection. That's a really interesting thing. I hadn't heard of that one before.
Yeah.
Well, Dr. Eken, why don't you talk a little bit about how you got into this field? I mean, why the field generally, and then why OCD in particular?
Yeah. So, I really, honestly, when I was back in medical school, I always sort of thought I would be a pediatrician, and I spent a lot of time in my rotations spending time with kids, and I just became really fascinated with family dynamics and how they impact childhood illnesses, or childhood illnesses impact family dynamics, as well as the whole mind-body piece. I worked with a lot of kids who had chronic medical illnesses who developed a lot of anxiety disorders, so that was just one of the big exposures that I had during some of my training. And so we would have kids with diabetes who had a lot of higher rates of depression or anxiety. So I just became really interested in that whole piece. And so there's this residency out there that you can do called Triple Board, where you get to do pediatrics and child psychiatry and adult psychiatry, and so it just seemed like a natural fit for me. Okay. So I had a mentor that guided me that way, just because of my I really couldn't see treating a child without understanding both sides of it, and that whole connection. And so I got into the OCD world eventually. I was actually in private practice in Louisville, Kentucky, and in a wonderful private practice there with a psychologist who did a lot of work with OCD. And sort of by being in the same office, there were so many kids who needed that treatment that I ended up managing medication and actually taking on some therapy cases with that. And interestingly, sent a child to Wisconsin to a Rogers program for really severe OCD. And through that, just became increasingly interested, and then actually went up there and worked and did really virtually, OCD, anxiety disorder, and eating disorder work. So I really enjoy specialty work, and sort of the it's very interesting to me, and these kids get better. Children and adults with OCD, there's a clear treatment that works for many people. Exposure response prevention, which is our preferred, modality of treating OCD. Sure. Just saw so much success with it, and that's, it's a really good feeling to help people get back their functioning. So,
say a little bit more about that exposure prevention therapeutic approach, Stephanie. Yeah. What does that mean?
Yeah, so it's a form. So people may have heard of cognitive behavioral therapy. That's a really popular intervention. And so exposure response prevention is sort of a specialized form of CBT. Mm-hmm. And what we do is we actually, most people with anxiety try to avoid the things that make them anxious,
yes.
Which is often reinforcing to the anxiety. And so what we actually do is, I'm going to go back to that example of OCD that I said before about, let's say, a fear of getting sick or mm-hmm. ill, is we would take a patient who had that, and we would actually have them do things gradually of exposing them to feared things. So we would have them, touch the doorknob that caused them anxiety. And why we do that, because it sounds like, oh my gosh, you're just making them anxious all the time, right? That doesn't sound like a very nice approach. And we do make patients anxious, but this really great process occurs called habituation. I'm going to explain what that means.
Okay.
And the best example I always think about is when we get, if ever anyone's ever gotten into a lake or to a pool and it feels cold at first, over time our body habituates to it, and actually the water feels warmer over time.
Sure.
And so what happens with anxiety is, just with the passage of time, if I'm touching, let's say, a doorknob that makes me anxious, mm-hmm. my anxiety is going to go up. Mm-hmm. It's going to come down over time. It might take minutes. It might take longer. And then I'm not going to go do the thing that I normally would. I would normally go hand wash, let's say, to get rid of those germs. But we don't let them hand wash. We don't let them do the ritual. And so what happens over that period of time is your body habituates that anxiety where it really doesn't cause you anxiety mm-hmm. anymore. Mm-hmm. And so we do that in a stepwise process so that people can now go, out in public and touch doorknobs and not worry that they're going to become sick.
I see.
And so we kind of give them the ability to, face these fears and really see that the environment in a lot of ways is not as dangerous as their OCD is telling them.
Yeah,
right?
and that's how I was thinking about it as you were talking about that. I was thinking, well, it's almost like you're having a person face their fears, but you're doing it in a very a gradual way, so it's not overwhelming to them. Is that correct?
Right. Absolutely. You're right on the money with that. So we do it in this gradual, stepwise fashion because we don't want them totally overwhelmed with anxiety.
Sure.
We want to do it in small doses. And then the really cool thing is things that they may have told us that were really anxiety provoking. So if you're using a scale of 0 to 10 and it's like a 10 for them because it's so anxiety provoking, actually by the time we get to that piece, it's often not a 10 anymore because they've learned from the other smaller exposures that actually their anxiety will come down and that there's not as much to be fearful of. So OCD really gives that idea, right, that there's a lot to fear that's erroneous. Mm-hmm. And we have to help them with those thought processes as well as exposing them to the fear. So, it's a really interesting process.
And, a lot of people may remember that old show Monk on TV, the guy who had these tendencies. And I think oftentimes we think of people who have OCD as being adults. And I'm not sure that we really hear quite as much about kids having these problems. But from what you're saying, it sounds like they do have these problems oftentimes.
Absolutely, yeah. So we see a lot of kids with OCD and other phobias. So some of those phobias that we see really impacting kids too are kids who are very fearful of vomiting or very fearful of choking, to the point that they maybe won't attend school because they're worried they might get sick and vomit. So it's quite common in kids. And if you actually, an average elementary school, let's say here in Nashville, it's likely that, 6 to 8 kids in an average size elementary school will actually have OCD.
Wow.
Yeah. So it's fairly common, and certainly other anxiety disorders too, generalized anxiety or separation anxiety is something that we see very often in kids. So we can actually use the same approach. Separation anxiety is normal at some age, but when, at certain ages it's not, and can be really cause a lot of dysfunction if they can't go to school or be away from a parent as well. So, yeah.
Yeah, I had it reminds me of a client I had. and a long time ago who was 5 years old, and his mother dropped him off at school, and he did not want to go to school because of the separation issue that you were just talking about. And
Right.
he ran away and ran into the street and was almost run over by a garbage truck. So,
Oh my gosh.
I mean, you
Yeah.
think you hear stories like this, and or even if a child is in school, just having to touch a doorknob if it's a germ, type issue, and how really this can have a major impact on kids, academically, socially, all those ways, huh?
Absolutely. Yeah. Yeah. We absolutely see it. It can have social consequences, or it can prevent them from being able to go to friends' homes, and do typical things. So,
Yeah.
and absolutely academically, we definitely see it impact them, because obsessions take up a lot of time in the brain too. So
Right.
it's hard to focus on, your math whenever
yeah.
you're worried about getting sick.
Exactly.
Yeah.
Well, do you
Yeah.
find that there are common themes or stories that seem to underlie the clients' problems? I mean, what's your take on why these clients have the problems they do? I know that genetics figures into it, but just in terms of the stories that you hear, do you hear any common stories or themes, anything along those lines, Dr. Eken?
Well, I mean, I think it's not uncommon to hear that kids have had certain stressors that seem to get things going from an anxiety standpoint, and it can be a gamut of things. I mean, certainly we hear things like when kids have move. That's a big stressor for a kid. So that can be an issue that kind of gets OCD or other anxieties sort of triggered. And then the other thing, there's just so much pressure on kids these days. There's so many stressors for them academically, and expectations from, all the things that they need to do to go to college and, get a job and all those things. I mean, kids, I think, have so much more pressure, even than when I was, in school, which seems like not that long ago, but it's getting further and further back. So, I mean, I think that's a really common thing that we hear before kids come to us, is just feeling stressed and pressure from daily life, those academic expectations and.
Well, how much
being able to be a kid?
How about perfectionism? Does perfectionism figure into the equation here at all?
Absolutely. And in fact, perfectionism for some people can be helpful on some level to help them be successful, but perfectionism is an OCD symptom as well if it takes up enough time and causes enough dysfunction. So that can be a significant problem, and it's often a trait that's encouraged by teachers and family members. And it just sort of depends on sort of how far we take it. So we actually treat kids for perfectionism types of OCD, and adults as well. So perhaps they're having to rewrite something so many times that they actually can't complete maybe a paper that they had to do because it's not perfect enough, or they have to sort of review what's going on in their head before they can say things out loud to make sure they say things perfectly. So it can be a real problem for them. And get to the point where they truly can't function instead of it being sort of a helpful piece.
Right. Well, I always ask my guests about their recipe for success in working with these clients, and we've talked a little bit about that. You had said that cognitive behavioral therapy is often a good approach. The exposure response prevention is a critical piece. The other thing I was going to ask you is the role of medication. Does this come into play at all?
Absolutely. I mean, for some people, their symptoms are not severe enough that they require medication. So we sort of say mild to moderate OCD does not typically require medication. Usually they can go and do exposure response prevention. Now, if we're getting more to levels of moderate to severe, then absolutely, medication's part of it. And that's part of what we do here, at Rogers. I mean, that's a big role for me as a, child psychiatrist. So, is to evaluate whether medication is required, and then what medication we should do. And, for OCD, it's SSRIs, or selective serotonin reuptake inhibitors, which are a form of an antidepressant. And people would know them, commonly as like Prozac, Zoloft, some of those. They are our first-line treatment if we're going to use medication for OCD. So we commonly use those. Sometimes we have to use other medications, but the combination of medication and cognitive behavioral therapy and in moderate to severe OCD has been shown to be the best treatment beyond either one individually. So if you compared, just medication to just therapy in moderate to severe OCD, typically the combination of the two is what gets us the best results and also prevents relapse in the future. So we've had some studies that show us that, which is, it's always nice to have research to back up our practice.
Exactly. Oh, yes.
Yeah.
And I imagine that, even though medication is effective, you've probably talked to parents who have had some concerns about placing their kids on medication. So how do you usually respond to them if they have those types of concerns?
Those concerns, yeah. I mean, every parent is concerned about putting their child on medication. It's a very normal part, I think, of just making sure you understand what's going on with your child.
Mm-hmm.
So, we talk about a lot of things. One is we talk about the risks versus benefit of a particular medication. So we'll talk about, possible side effects, and we'll talk about the evidence for the medication. What does the research say, and why do we think this is effective? And then I also talk to them sort of what are the risks and benefits of not doing medication. So, maybe their child is not going to school or really struggling to get to school, and you've done therapy and it's not working, by itself, so we've got to do something else. And there are risks to not, sort of having those interactions at school academically as well as socially. So there's the other side of if we don't intervene enough as well. So, these medications for many people are very safe. And the great thing is if you have a psychiatrist to help manage those medications, is you can talk to them and see, is this helpful? If not, we can change it. So I think it's important to have somebody that you trust and feel good about to help manage those medications.
Right. Yeah. So it's really a cost-benefit analysis, isn't it? When you
really
sit
is.
down and talk to parents about this, and ultimately they have to make that choice. Now,
right.
You've probably had several clients over the years who have been quite challenging, and perhaps you could share a little bit about some of those cases and what do you do to deal with those challenges?
We definitely get some people who have a lot of impairment. I can, a lot of cases come to mind, but something, that I think we see in the child and adolescent population is how we work with parents to be co-therapists with us, and I think that's really important when we have especially a very challenging case. So I can give you an example of, a patient, a teenager who had contamination fears, but interestingly, it wasn't germ contaminations necessarily that they were worried about. It was contamination from another person, and it was actually a parent. So they worried, that not only could they potentially take on personality traits of a parent that they didn't necessarily really like, but that parent also had some medical problems, and they worried that perhaps they would develop those medical problems if they touched that parent. You can imagine how challenging that would be, right? Because this, they didn't want to live with that parent, actually, because they were so fearful that these negative things might happen, and that really impacts the relationship. And that parent was doing what they thought was the right thing, but was reinforcing anxiety. So they actually, allowed them not to go in certain parts of the home, and actually ended up having them live with someone else for a period of time, instead of living in the home with them. And that's a big decision too, as a parent. But it was really, really difficult. And the teenager essentially said, "I'm never going to live back at home with you." And so we worked, obviously, doing exposures with the patient, and we worked a lot with the parent as well in trying to take away what we call accommodating behaviors. And some examples might be an accommodating behavior might be if somebody wants to wash their hands a lot, your child does, and you go buy them like a lot of soap so they can continually wash their hands, right?
Sure.
So you're sort of facilitating their rituals. And so we worked a lot with that parent on not facilitating the rituals and the avoidance of their child. And so I think that's some, and then we also used medication as well. And the great thing is at the end of it, the teenager was able to go back and live with their parent which is a great success. But there can be, a lot of barriers to people getting better. And so, it took time to convince them to do some of the exposures too, right? Because they were very worried.
Right.
And they knew our end goal was to get them back in the home, and they very much didn't want those things. So you use other techniques to, like, to help with motivation.
Sure.
And to help them see long-term. So we talk a lot about long-term thinking, because OCD is a lot about short-term thinking.
Right. Well, what's interesting about that is that we were talking at the beginning of this podcast episode about, what are the causes, and we talked about genetics and stressors and things of that nature. And in this example, what I thought was fascinating was the role that family can play in terms of enabling behaviors, is kind of how I was thinking about that, and how family really can play a part of this whole issue too, huh?
Absolutely. And so I think, I always say OCD takes advantage of parenting, of typical parenting, because, often you can reassure your children that nothing bad is going to happen, and they'll take that information and they can use it. Or, you can just do these things with kids who don't have a lot of anxiety. But whenever you have a child with a lot of anxiety or OCD, you do, if you give them reassurance, you actually start to figure out, oh my gosh, they're just asking for more and more.
Right.
Or you think it's easier, like, oh, if I just help them, wash their hands again, then we can get out the door and go do this thing. And so they do it in the beginning because it's easier, and they think they're doing the right thing, and they don't want to see their child in distress, right? It's very hard to see your child really anxious and in a lot of distress. And so, but then, because they're not OCD experts usually as the parent, the snowball sort of starts happening where they're doing more and more to facilitate, these rituals and enabling them. And so all of a sudden they get to this point, they're sort of like, how did we get here? So we actually do something specifically called Parent University as part of our programs, to help sort of reprogram ways they're going to handle situations with their kids, because it's got to be from a little bit different perspective. If they're always helping them avoid situations and not face their anxiety, it's a problem. We want to always have the idea that facing fears is always the best route for us to go, and that's hard as a parent. So we want to give them support to do that.
Well, I love that idea. I mean, that because to me the whole Parent University idea is like an educational component, and parents really need to be educated about what's happening here. They might have tons of questions about this, and I think something like that, to answer questions, to look at family dynamics, I think all of that is such a critical component of the care of a child who suffers from this kind of disorder.
Yeah, it's really key for them to maintain those gains, when they leave a program like ours too. Yeah.
Well, if a person is listening to this podcast right now, what is it that they should consider in terms of deciding who to seek out for help? Because there might be a lot of therapists out there who just do counseling and just all that kind of stuff. But for something like this, what is it that they should look for in a therapist?
Yeah, so I think it's important to look for that background of CBT, and you'll want to ask specifically if you have OCD, you'll want to ask if someone does exposure response prevention. All right. There are some resources for people to go to that I think can help them find these type of therapists. So the International OCD Foundation, they have a really nice website where you can look up, like based on your zip code, therapists who, list themselves as doing this kind of work. Also, the ADAA, which is the American Depression and Anxiety Association, they also have those type of listings where people might list that they do CBT or ERP. So I think it's important, to try to find people who do those particular interventions. So, if you find somebody, you can also just, if you call them, you want to ask, because just regular talk therapy for OCD is just really typically ineffective.
Okay, that's a good point. And we'll list those links to those associations that you mentioned in the show notes, so if a person wants to go check those out, that they can do that. Now, for the Rogers program, is this something that's a little bit more intensive in terms of types of services that are offered?
Yeah, so we don't do any like what we would call regular outpatient work. So we don't do anything where we see like patients once a week. So if they're coming into Rogers, if people just want to call, because we tend to know some of the resources around OCD, if they just have questions, they can always call us, and I can provide the phone number. But if certainly if OCD is having a significant impact on someone's ability to work, go to school, have relationships, then something intensive like our partial hospitalization program might be really appropriate. Our intensive outpatient program is 3 hours a day, Monday through Friday. And sometimes we have people who've never seen an outpatient therapist and who come to us because, it's taking up enough hours in their day that they don't want it to be that way anymore. And
right.
It's, they want to get better, and they like that, we have, psychiatrists here who can manage their medication. So, what I always say is, if you think you might need us, then give us a call, and we do a free screening and make a recommendation on level of care, including if we believe that you don't need us, if you just need an outpatient, provider, and we can help with some of that direction.
And I think a parent who's listening to this might wonder, well, if I want my child to be part of this, if it's serious enough problem that they want the child to be part of this, will the child miss school? I mean, how does all that work?
Yeah, so it depends. So if they're in the partial hospitalization program, they actually do miss school because it goes from 8 to 2:30. But we actually do school for an hour a day with a certified teacher at the beginning of the day. So we collaborate with the schools and try to get work from the schools so they actually can do some of their schoolwork here. Obviously, they're not going to get as much done in an hour a day as they are at a full day of school.
Right.
And then our IOP program, we actually run it from 3 to 6, so 3 p.m. to 6 p.m., so that kids can go to school during the day and then come to our program afterwards and do that piece. Yeah.
Great. Okay. Well, Dr. Eken, this last part of the interview is what I refer to as make a mental note. And it's something that you feel is important for the audience to make a mental note of in terms of improving their mental health or relationships. And so if you could just offer one tip or suggestions, word of wisdom that might help an audience member improve their mental wellness or relationships, even if just a little bit, what would that be?
Wow, well, there's a lot of things I can think of, but I will try to keep it down to one or two.
Okay.
One is, I think, if you're going to seek treatment, to look at, types of treatment that have evidence, behind them. And I think there's a lot of different variations out there, but people have to find sort of what fits them and that has some type of evidence behind it.
All right.
And then the other piece, I think, as I mentioned before, there's so much stress, I feel like, in the world today. And so, I think finding time to, as an adult or children, to find that space where you can do things that are important to you individually, and make time for that. Make it a priority to take care of yourself.
Yeah, I agree.
We don't do that very often.
You're exactly right. I think the whole issue of self-care is a very important one, and I think that really needs to be taken into consideration more seriously. I like to hear you say that. So, well, if a client or parent wants to contact you, or if they're interested in setting up an appointment with somebody at Rogers, how could they do that?
Yeah, so we have a couple of ways that people can do that. One is we have, a toll-free number that they can call,
all right.
And it's 844-615-3221.
All right.
So they're always welcome to call us that way. We have a website. It's Rogers, so it's Rogers, B as in boy, H as in health, so RogersBH.org, and then you'll see Nashville's listed on there as one of the sites, and you can actually request a screening online as well. So, so you can do it that way or call us.
That sounds great. Well, I really appreciate everything that you've talked about today. It's really exciting to hear. This is a new program in our area, and I think that you're going to get a lot of people to take advantage of this. And it was nice talking to you too, Dr. Eken. It sounds like you're a very easy person to talk to. If a parent had a child that they wanted to see you, or part of this whole program, that they would feel very comfortable talking to you. So I appreciate everything that you've done, taking the time out of your day to join us on the Make a Mental Note podcast today.
Well, thank you. Thank you so much for having me. I really enjoyed it.
Okay, thanks. And have a great rest of the day.
Thank you. You as well.
Okay. All right. It's nice to see what Rogers Behavioral Health Systems has in store for the Nashville community. I think that, sometimes kids and adolescents are shortchanged in terms of mental health services. And so having something like this in Nashville is a welcome addition. Well, I always like these podcasts to be a learning experience, and I wanted to ask you a question. What is the primary method of helping kids and adolescents with obsessive-compulsive disorder? You remember what Stephanie talked about in terms of an evidence-based treatment procedure? Well, it was called exposure response prevention, and it's a special form of cognitive behavioral therapy. And people with OCD engage in rituals like hand washing in response to obsessions like germs in order to get rid of their anxiety that's brought about by those obsessions. And so with exposure response prevention, basically it involves interrupting the pattern by preventing the person from doing the ritual, and to instead expose them to the thing or the situation that they fear. And that's done in a slowly, non-threatening way. Stephanie talked about this being done in a stepwise fashion. And so repeated exposure to the feared object or situation will eventually reduce the fear and the need to engage in the compulsive behavior. She had talked about this as habituation. So this is the primary method that's used. And so the takeaway from today's podcast is that kids who learn how to confront their fears that are brought about by obsessions with evidence-based approaches such as exposure response prevention won't feel the need to engage in compulsive behavior to alleviate their anxiety. Okay, thanks again for listening to this podcast. Please visit my website, chrisquarto.com, for show notes of this episode. And once again, if you liked what you heard today, please get the word out on Facebook and Twitter. Let people know about the Make a Mental Note podcast. All of the Make a Mental Note podcast episodes are available on iTunes or Stitcher Radio or on my website. Have a great rest of the week, everyone.